Hi, welcome everybody, and thank you so much for listening to our talks this morning. Just to reintroduce myself, my name is Louise Connell. I'm a GI medical oncologist working at Memorial Sloan Kettering Cancer Center in New York, and my specialty is in colorectal cancer. And I'm here with my colleague Sam, who introduced himself, and then we'll get going on some of the questions that came through.
Sure. Thanks, Louise. Sam Klempner. I'm a GI medical oncologist at Mass General Hospital in Boston, and my clinical and research focus is in gastric and esophageal cancers primarily.
Okay. So maybe because we just finished your session, Sam, we might follow up with some of the questions that have come through for you. I think some of these have been answered already in some of the online chat, but maybe you can expand a little further. So one of the first questions that came through was, whether the use of nivolumab in combination with chemotherapy should be considered for all patients, regardless of their PD-L1 status.
Yeah, it's a great question and a huge topic, probably whole separate talk on PD-L1 testing in gastric and esophageal cancers, but I assume this question is in relation to Checkmate 648, which was a big phase 3 trial in squamous esophageal cancer presented at ASCO this year. And definitely what we've learned, and I think is reproduced across the trials, is that we can identify the patients who derive a greater magnitude of benefit. So the PD-L1 high, CPS 5 or 10 cutoffs are deriving the most benefit. But within the squamous population, it does seem quite reasonable, in my opinion, that PD-L1, in addition to chemotherapy, is relevant to all of the patients. It's a population that do derive a little bit greater benefit and activity from these agents than the adenocarcinomas in general. And so I think based on the data that's been presented from Checkmate 648 and Keynote 590 back at ESMO, there's pretty strong rationale to give a new squamous patient who walks in your office and has advanced disease chemotherapy plus IO.
Okay. And then, in terms of talking about the chemotherapy backbone, then, I mean, cisplatin was used in combination with 5-fluorouracil in this trial. And I guess, again, another question that's come from our audience is that not every patient is eligible for cisplatin. So, what are alternative chemotherapy regimens to use in combination with IO in these patients?
Yeah, very, very practical and very good question. I think, I imagine this person is thinking along the same lines as all of us, that oxaliplatin is really our strongly preferred agent. And the reason for the chemotherapy backbone in a lot of these trials is sometimes practical and sometimes practice pattern related. So opening trials internationally where the standard may be cisplatin in another country, particularly in Asia, in order to have accrual globally, sometimes it's just required for the protocol. But completely agree with this person, and I think many of us in the US long ago have stopped using cisplatin in the frontline setting and feel completely comfortable extrapolating to 5-FU and oxaliplatin, all of these data sets. So for example, Checkmate 648, I think many of us would look at FOLFOX or CAPOX with nivolumab as a very palatable alternative to the chemo that was necessitated in the protocol.
Okay. And then, to follow up, I think a lot of questions are coming through on this one study, but, again, in your practice, would you lean more towards the IO-IO combination versus IO in combination with chemotherapy? I have to say, as I'm not an esophagogastric oncologist, but I was surprised actually that the chemo-IO arm was more effective essentially to the ipi-nivo. So we'd be interested in your thoughts on that.
Yeah, I agree with you. And I think the thinking around the ipi-nivo, I mean, I would commend the trial for investigating a chemo-free arm. I think there's a lot of attraction and sort of inertia to want to give chemo-free regimens, particularly when we see some things like, we'll talk about in some of the trials that you reviewed, where in some patients, chemo-free regimens can do fantastic. Unfortunately, outside of the MSI high population in upper GI cancers, chemo-free regimens have really not quite lived up to the potential promise. And my opinion and interpretation of Checkmate 648 is that Ipi/Nivo is active, and there's definitely a tail of the curve. There are people that have durable responses, and it did appear to be superior to chemotherapy alone. It was not compared against chemotherapy plus nivolumab, and sort of within trial comparisons, the response rate is lower with Ipi/Nivo than chemo/Nivo. And to me, in my personal practice, I think it would be very unusual that I would be picking Ipi/Nivo over chemo/Nivo. Also, the caveat that Ipi/Nivo is actually not approved in the current regulatory environment. We're waiting for feedback from FDA on whether or not Ipi/Nivo will be considered as a frontline option. But chemotherapy plus nivolumab is available. Yeah.
Okay. And then one final question that's come through so far is looking at some of the scheduling in terms of nivolumab and why it was chosen as Q2 weekly over 4 months in this particular study.
Yeah, so I think this question is probably asking about Checkmate 577 perhaps. And so this was a really important trial, and honestly, maybe one of the most important gastric and esophageal trials in the recent time. And it asked a really important question, which is, can we do anything after trimodality therapy, which is chemoradiation and then surgery?
Yeah.
We know that people who have less than a pathologic complete response, which is about 75 to 80% of our patients, have a high recurrence rate. So that the median disease-free survival for someone who has residual disease at the time of surgery is around 10 or 11 months. That's a really short time for someone who just went through a lot. So the question of whether or not we could put anything in the adjuvant space to reduce the recurrence risk is really a very clinically relevant and practical question. And so the trial examined nivolumab or nothing, placebo, for 1 year after trimodality therapy. And the take home from the trial was that they doubled the disease-free survival from 11 to 22 months. And this was really a practice-changing trial right as soon as it came out. It's now published in New England Journal of Medicine and approved by the FDA. The schedule initially, so patients had to start therapy within 16 weeks of their surgery. And this just tells you how long it takes to really just start your recovery from an esophagectomy. The schedule was nivolumab every 2 weeks initially, and then converted to the every 4-week dosing. And there isn't really a scientific rationale as to why this would be the preferred approach, but practically speaking, I think it's important to see these patients relatively frequently in the early time points after recurrence. And I think they were smart to sort of mandate that because, one, for toxicity assessments, you want to make sure that your adjuvant therapy is not delaying the recovery or impacting the quality of life, which the data suggests that it did not. And then, again, with an attention to practicality and real world, once the patients have achieved a relative degree of stability after surgery, switching to a monthly dosing is certainly much more convenient. And so I think the schedule is primarily related to more practice-related factors than scientific rationale in this trial.
Right, but important to see the patient, as you've said, right? Okay. So we've another question that's after coming through actually, which is looking at a patient with stage 4 gastroesophageal junction adenocarcinoma, HER2 positive, responding to first-line Herceptin, Taxol, and carboplatin. Is it worth changing the chemotherapy to FOLFOX now or wait until progression? Interesting question.
Yeah, interesting question. A little bit outside some of the data that was covered, but the trial that we talked about was Keynote-811, which suggests that pembrolizumab, in addition to 5-FU, platinum, and trastuzumab, is impressively active with a substantial improvement in response rate. So, if you saw this patient now, you might say, well, we can offer the patient 5-FU, platinum, trastuzumab, and pembro if there's not a reason to. That's FDA approved. In this particular clinical situation, I'm sure there was a good rationale for carbotaxol and Herceptin in the front line. In a patient who's responding, I think there isn't a clear reason to suggest the need to switch. I think that 5-FU and platinum is the standard frontline therapy, and this is a little bit of a deviation from the standard frontline approaches, but certainly it's working for this patient, which is great. So I don't see a clear rationale to change in the setting of an ongoing response.
Okay.
Yeah, I see a fair amount of lower GI questions coming in. Should I transition to throw a few your way?
Yeah.
So I think similar to the question you just asked me about dosing and schedule, I saw that one of the questions came in about use of the 400 versus the 200 milligram dosing of pembrolizumab. And maybe if you can speak to your thoughts and whether or not you think it's reasonable to use that interchangeably.
Right. So again, a very interesting question. And I think I would answer in a similar way to how you did, in that, at least in the beginning, I prefer to see people regularly when I start them off on treatment to assess tolerance of the regimen. The 400 milligrams Q6 weekly is FDA approved, and this was across all cancer types. It was approved last year, I think April of last year, and it was based on pharmacokinetic models and looking at exposure analysis. So scientifically, yes, we can do that. I think in practice last year, a lot of us were doing that for patients because of the COVID pandemic. And I certainly do use it in patients. Now, as we're emerging from the depths of the pandemic, when I start somebody off on pembrolizumab, I do myself see them every 3 weeks before I consider switching them over to a 6-week regimen.
Yeah, I think that sounds like a very patient-centered and sensible approach. I would completely agree. There's a couple questions here about later line colorectal cancer, and maybe you can speak to the abstracts that commented on this, and then particularly the sequence of regarding Lonsurf and regorafenib, which is one of the questions. Do you give Lonsurf or regorafenib first?
Okay, yeah. So again, I think, when we come to third line treatment options in colorectal cancer, it's very variable what we offer for patients. Truthfully, in practice, I'm not a big fan of Lonsurf or regorafenib in my patients. And if I have a fit patient, I really try to get them on a clinical trial. Versus, again, depending on response to an oxaliplatin or irinotecan-based regimen and what their toxicities were, I'll often, recycle oxaliplatin in patients or some of the drugs that are already used, as opposed to moving on to Lonsurf or regorafenib. In the patients who I can't do that or who are not eligible for a clinical trial, I have a very detailed discussion with them around the data for Lonsurf and regorafenib, the clinical benefit, as well as life on the treatment. And once we have an informed discussion and a patient really wants to pursue therapy, I typically use Lonsurf first. The reason that I do that, truthfully, is because a lot of these immunotherapy studies that are emerging in MMR proficient colorectal cancer, they can have regorafenib included, possibly. So I want to keep some options open for patients, and therefore I tend to lean towards Lonsurf ahead of regorafenib for that reason. But to be honest, in practice, they're not drugs that I commonly use. And if I do use them, it's after a very detailed discussion with the patient and having a very low threshold to stop if they're finding that their quality of life on treatment, is severely affected by the drugs.
Yeah, thank you. And it sort of to build on that, are there situations where you use Lonsurf and Avastin? One of the panelists, one of the attendees is asking.
Right. So I think, we do have data in the third line setting that Lonsurf Avastin has a certain higher efficacy over Lonsurf alone. And again, if I have a patient who's fit, I think it's a more attractive option than Lonsurf alone in patients. I certainly wouldn't advocate it for it in the second line setting. But I think in the third line, it's definitely reasonable to consider. Talking about different combinations, one other option that I do consider in patients is regorafenib in combination with nivolumab in a patient who really is not eligible for any clinical trials. I see a lot of young, fit patients in my clinic, unfortunately, in their 30s and 40s. We want to give them exposure to immunotherapy. If I don't have a clinical trial, then I will off protocol combine regorafenib with nivolumab in those patients. So definitely looking at the two options, Lonsurf with Avastin, I think is reasonable versus regorafenib with nivolumab. Again, the patients need to be counseled on the low response rates, a low threshold to stop depending on toxicity. And I'm a big proponent for quality of life and knowing when is the right time to stop in the individual patient.
Yeah, we when we get into the third line in gastric and esophageal, very similar, and unfortunately, very, very limited activity of any of the approaches that have been tried in after second line therapy. There's another question about dose and schedule. Really, I guess it's kind of to both of us, which is how long do you treat, say, every 3 weeks before considering a switch to every 6, and then with nivolumab every 2 before a switch to every 4. I'll mention briefly for adjuvant esophageal. In the study they did every 2 weeks for 16 weeks before switch to monthly dosing, and I think that makes a fair amount of sense because it's really those first 6 months after an esophagectomy where patients are still going on for a lot of recovery, and so that takes you out to most of that time point where you're seeing the patient relatively frequently. That being said, in practice, for similar reasons to you with the COVID pandemic, we've also been certainly switching to a monthly dosing before that 16 weeks of every 2-week dosing a few times. But in your MSI high patients, Louise, how are you, do you have a set timeline that you switch from 3 to 6, or is it sort of individual?
The honest answer is if I start them off on the 3-week, which I tend to do in all patients, is, I'll get them to the first scan. I'll scan them after 4 doses and see. And, if I really have people who are doing fantastically well, then we'll switch to the 6-week regimen, versus in other patients, I might get them to the second scan. So, the way that I word it with them is we'll take it scan by scan. And I definitely individualize, based on the patients that I see. Also, I think a big thing for me is, where I work, a lot of my patients are traveling long distances to come and see me. And, so they're not close by if they have a problem. And, that's where I really need to, as part of the routine practice, instigate that they're seeing me regularly so that I do have a good understanding of what's happening with them. It's very rare for me to see people living in and around Manhattan with people traveling long distances to come here. And it just makes me uncomfortable if I don't know what's happening for them. But I do take it scan by scan.
Yeah, makes total sense. Sort of to build on your discussion of Keynote 177, what do you think about the role of IO? So in this case, ipilimumab and nivolumab in MSI colorectal cancers.
Right. So I think we have evidence to support the use of ipilimumab, nivolumab in combination in MSI high. Another question that came up during the online chat is, why we're using immunotherapy alone, right? And why we're not using the IO chemotherapy combinations. And there are ongoing trials which are looking at that in both MSI high patients and also in patients who are MMR proficient. In terms of the MSI high, there's a phase 3 trial ongoing, which is basically looking at atezolizumab as the immunotherapy option versus folfoxavastin with atezolizumab versus folfoxavastin alone. So, I think we're exploring these options. I think right now there's been a shift, right, in terms of we have evidence to support the use of pembrolizumab as a single agent in the first line setting, and that's what we should be doing in our MSI high patients. And again, it's looking at the toxicity profile, right? Single agent pembrolizumab, had a very good toxicity profile in this study, is very manageable for patients versus the added toxicity of ipi-nivo. But certainly in those patients who, for example, are already treated before we had the data from this study in the second or third line setting, for example, ipi-nivo is certainly reasonable to consider.
Yeah, we're Checkmate 649, which was a big frontline gastric and esophageal trial. There was an arm that enrolled a fair number of patients with ipi-nivo, and we have yet to see that data. So certainly there's similar themes in gastric and esophageal, but we don't have really data in the adenocarcinomas. We have squamous data as we discussed. Yeah. There's a question, maybe I can try to take this, about the risk of...
For capecitabine?
Yeah.
Yeah, so the increased risk if you need to decrease capecitabine by 1/3 due to lack of appetite and dehydration. The medication was used as a prevention, so adjuvant therapy after resected Whipple, biliary tract involving lymph nodes, okay?
Yeah, so I know we didn't cover this exact question in the abstracts, but certainly there's a trial called BILCAP looking at adjuvant capecitabine after treatment for your surgical therapies for biliary tract cancers. And the activity is there, so I think there's some rationale to take this approach, but the survival advantage was not clearly shown in the overall trial. So I think we always ask ourselves in the adjuvant setting, especially when there's some tolerance questions, are we sure that we're definitely adding? So if this person has been on therapy for already quite a while, and they're really unable to tolerate, then early cessation is not unreasonable in this situation, especially given the data. I don't know exactly what risk the attendee is referring to. I presume risk of recurrence. And I think I think when drugs are reduced for toxicity, it doesn't always come with a decrement in efficacy, but that does happen at a certain level. I mean, there are doses probably under like 625 milligrams per meter squared. You may be losing some efficacy, but again, I don't think we have data to specifically say that. So I would say if the side effects are manageable, the risk, of course, is recurrence, but in this situation, it may be a reasonable consideration to perhaps have a discussion about the risk benefit of completing the entire course versus an early stopping. I don't know what your thoughts are in the setting of adjuvant management in general. I know you talked a little bit about it.
Yeah. So, I mean, I think, again, it's something that, you've got to weigh up, again, exactly as you said, right? If somebody has had a lot of treatment prior to surgery versus, what are you gaining from the adjuvant therapy, looking at life on treatment and balancing the toxicity with the recurrence risk. I think with capecitabine specifically, I would say I tend to, go on the lower end with dosing than higher, because I think inevitably patients end up needing dose reductions. So, if someone is between a 1500 to 2000 milligram BID dosing, I'll pick the 1500, for example, because I think they can more consistently stay on the drug versus starting them high. They get severe toxicity. And then we need to stop it completely. But certainly I've had patients who cannot tolerate the adjuvant regimen, and we stop. And I instigate closer monitoring initially to ease concerns that they have, because they've become so invested in the adjuvant approach. So that's what I do. So I think we've actually run out of time. We just want to say thank you to everybody for your time. Now we're going to take a quick break, and we'd like you to use this time to earn some points toward the Engage and Win giveaway by chatting with the industry representatives in the exhibitor hall. Within their booths, you will find helpful resources and information, as well as the ability to talk now with an available booth representative. Thanks, Sam, for the discussion, and thank you to everybody for their time.